Hi, Uma.
Hi.
Hello. I have, given permission for sharing screen. Do you want to quickly check it out that you are able to share? Yeah.
Yeah, it's moving. Yeah. Okay.
Perfect.
Okay. So that works. Now, sometimes, even if we've done it a zillion times before, on the day of the thing, something will happen.
Yeah, that's the beauty of technology. It's working now. Hopefully, it continues to work.
No. I know it'll work. It's just that sometimes once we install updates or whatever, no, those permissions go off, especially on a Mac. So it's not worth assuming it'll work.
True.
Prudent to check. I thought Sushila logged in, but I think she logged out again.
Hi.
Hello. Hi.
Hi. This is Rotarian Samina.
Yeah. So we have also the guest speaker today, Uma. We are waiting for. I mean, it's anyway 6 minutes to go.
Hello.
Hello. So how come it decided as a virtual meeting today?
Yeah. We are alternating because then we can also, attract a lot of good speakers where we don't have a location restriction.
Yeah. Okay.
And anyway, it's also pouring. So in a way, hindsight, it is good that,
Yeah.
we are giving people time instead of needing to travel.
True. That's good. Yeah.
I'll be on mute for some time till people start joining.
Hi, Narayan. Can you see me, hear me?
All loud and clear.
Brilliant. Thank you.
Hi.
Well, hi, Uma. Good evening.
Good evening.
Thank you so much for agreeing so readily. Very sweet of you.
No problem. Sushila, one can't refuse.
So that was a good psychological move there. A busy day for you, or evenings are normally light?
Thursdays are actually quite busy. Thursdays and Saturdays for some reason, but I like 7:30 is okay. I managed.
Chennai, aren't you, right now?
Yeah, Chennai.
Not traveling or anything.
No, no.
Brilliant. Quite a powerful PowerPoint pack. So from what I can see, it's on the mother's side and the pregnancy and that kind of thing, right?
Yeah.
Of-
So
of-
she said something to do with maternal health.
Yeah, correct.
Mm.
So what happened, just so that you know, Rotary has what they call a theme.
Mm.
And every month they have a theme. So this month they're kicking off, the Rotary year kicks off on 1st July. So we're just the second meeting of the year.
Mm.
And the theme chosen for this has been maternal and child health.
Mm.
That's the reason Sushila immediately thought of you. So, hi, Sush. It's a bit dark in there.
I think Sushila is on mute.
It says need to be unmuted.
Hmm. Shouldn't be the case. Allow participants to. It should work.
Narayan, there's a request from Sushila asking you to unmute her.
Yeah, done that.
Okay.
Because all of you joined, right? It was.
Yeah, I could click on the bottom left and I had no issue.
Exactly.
Madhu, are you able to hear us? You're on mute.
Yes, I can hear you and see some of you, but I'm not able to come on video.
All right.
No worries. Okay. Sushila, maybe you can drop and try to join again. Maybe some glitch.
Am I visible now?
Yes, you are.
Yeah.
Okay.
Looking professorial with your specs, I must say.
Hi, Samina.
Wow, we have Rani Ramakrishnan joining us all the way from US. Wonderful.
Okay, I think I'm there.
Cool.
ID have you?
Okay.
Connect at Rotary dash.
Yeah. I'm in Gargi. What about you?
No, I haven't been. So it's a new ID,
Okay.
right?
Narayan, you need to let Gargi in.
I have opened up. Everybody can. I don't have to
Okay,
admit
you can
anyone.
join.
Everybody can just join in directly.
Yeah, you can just join Gargi. Try again.
Okay.
It's muted.
Hi.
Hey, Ravi.
Hey Ravi, hi.
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 Hi, Prashant.
Power cut in area, Prashant?
Sorry?
Power cut in
Dash.
area.
I can't hear. One sec. Something wrong with mine.
I'm thinking about the money now. I have to get that house set. Look at that mess. Well, that's what Jan's right. We gotta help this house get pulled together. I'm gonna run and get some coffee. You guys can start, okay?
Hi, Uma.
Sorry, Dash, were you saying something? So sorry, I missed you.
And I was just kidding. I said, is there a power cut in the area because the lighting seems.
No, I'm a handsome Dravidian. So.
DMK is looking for people like you, mate.
Yeah, I'm already with them. I've always
After,
been with
after Palnivel, you're the next best bet.
them. He wailed a little too much.
Hi, guys.
Hello.
Hi.
Shivu.
Hi, Dash.
Anyway,
Hi,
nice to
Narayan.
see you, Dash, after a long time. Yeah.
Sorry?
Thank you.
I'm saying Dash, nice to see Dash also after a long time.
People make New Year resolutions. I made one for the Rotary New Year.
Great.
So,
Okay,
Prashant,
we are waiting for the president to join.
She said she was trying and was not able to.
the meeting's going to start.
Suman hasn't got an idea.
Behind time.
Suman is not joining Dash. So Narayan is going to be standing in for Suman.
Good.
Better, Dash?
Yes, indeed. Indeed.
Hi, good evening, everybody. Just driving, so not switching on the video or audio.
Nikant, I hope you're not in the Ducati. Are you in Ducati or in the car?
I'm in the car.
The profile looks like you're riding on the bike. So I was like, At this
No,
time-
that's my profile picture.
nice bike.
Thank you.
Where's everybody? Ramakant, Raju.
Let me try Gargi again.
She called me. I've again sent her the link. She said she's not able to join. I said everybody else is in, so it's
Okay.
definitely not a
That's-
technical issue.
That's fine.
You just give a minute. We are over 7:30 now.
Oh, Gargi is having a problem with the connection, is it?
Yeah, she said she's not able to join on the link, but
Okay. I think 472. Let's start. Who is there? I mean,
so can we call the meeting to order without the president?
No, you can't.
It's correct, but it ain't fair.
that's true.
Can't any of the past presidents stand in and start it out?
I think we don't know what announcements she was going to make and so on. So
You can call the meeting to order. I am standing in behalf of Suman, so I will do the announcements.
I don't know. I mean, Dash and Sushalaj and all that should, and all our senior, even we don't know. We can stand it for the president person.
yeah, point we're making is we can stand in for the president, but whatever announcement she would have been planning to make would be in her folder.
Oh, so you can, okay. I presume that, okay, because that
Yeah, I
coloring
think
thing
Gargi
is.
is, yeah, I just saw Gargi in.
Okay, great. Okay.
She's there, not on audio yet.
Disconnecting, I guess.
Good evening, everybody. Sorry, there was a first meeting hitch.
Okay.
Right.
Hi.
Hi, everybody. Should we start?
Request everyone to mute their mics, please. I mean, if
Yeah.
admin and Narayana can just mute them.
Yes. Please.
Yeah, Gargi, you can start.
Yeah, I can start. I call the second meeting of the year, Rotary year 23-24 to order, and let us start the proceedings. First, let us have the 1 minute silence, please. Thank you. May I have the secretary's announcement?
Thanks, Gargi. So I'm standing in for Suman today. So I'll start with the birthdays for the week. 8th July was Rohit Karnat's birthday. And 17th July is Anne Geetanjali Venkatesh's birthday. In terms of wedding anniversary, 9th July was again Rohit Karnath and Ramya's anniversary. And 19th July is our treasurer Mithun Pai and Anne Divya's anniversary. In terms of committee meetings, we have the first committee meeting of the club admin tomorrow, that is 14th of July, which is being conducted at Century Club and I'm hosting it. And 15 July is the community committees meeting, and this is at Boring Institute. It is being hosted by Sriram Bashyam. So these are the announcements, Gargi, from on behalf of Suman.
Okay. Thank you, Narayan. Now I would request Rotarian Madhu to give a short talk on lactating mothers. Madhu, over to you. Please.
Yes, thanks, Gargi. So I'll be briefly outlining a project, a maternal and childcare project that was started 2 years ago. It's called Mom and Me. Now, maternal care is one of the key focus areas of Rotary International, and it is estimated that 5.9 million children under the age of 5 die each year worldwide because of malnutrition, inadequate healthcare, and poor sanitation. The nutrition of the expecting mother has a direct bearing on the infant's well-being. India is ranked 97 among 107 countries in the Global Hunger Index 2020 and falls under the category serious at a score of 27.2. Being conscious of this, the Rotary Club of Bangalore Cantonment, RCBC, is focusing on maternal care to contribute its efforts to mitigate hunger and reduce infant mortality with its Mom and Me project. The objectives are to improve the nutritional standards of the mother-to-be and the new mother and infant, and also to encourage basic health requirements, hygiene and nutrition to mothers and infant, and decrease the malnutrition in this target segment. The project itself, a brief description of, The mother is defined as an expectant mother 6 months pre-delivery until the baby completes 24 months, 2 years. So a potential of 30 months totally. These new mothers are identified from socioeconomically challenged backgrounds. A mother can be enrolled only once in the program. Currently, RCBC covers 25 mothers under this program, and we plan to expand the program to cover around 40. The nutrition kit includes a balanced diet of rice, lentils, ragi, jaggery, cooking oil, and dry fruits, which is sufficient to last 1 month. The operations, each enrolled mother is given an ID card, and the monthly nutrition kit is given on the last Saturday of the month. It's handed over in the Rotary House of Learning. The date and time of distribution is notified over a WhatsApp message, and the kits are handed over to the mothers who produce the ID cards. Every alternate month, at the time of distribution, sometimes special programs were held. For instance, guidance sessions on balanced diet or child health, gynecological consultation, etc. As far as the financial outlay is concerned, rupees 1,200 per month is the estimated cost of for per mother and infant beneficiary. 3.5 lakhs have been spent over the last year with an average of 25 beneficiaries per month. This was supported by a CSR grant from MOOG. That's it from me. Gargi, over to you, or if anyone has any observations or questions.
Okay, I guess no one has any question on this. So thank you, Madhu. And now I'd request past President Rotarian Shushila to introduce today's speaker, Dr. Uma. Shushila, over to you.
Thank you, Gargi. Thank you, Uma, for agreeing to do this talk for us. I have great pleasure in introducing Uma to our audience today. Dr. Uma Ram is the director and lead consultant in obstetrics and gynecology at the Seethapathy Clinic and Hospital in Chennai. She has almost close to 3 decades of experience as a medical practitioner and is one of the best regarded gynecologists in Chennai. The thing about her that I've heard from others, some of her patients, is that the way she approaches the patient is not as, not as in the typical doctor relationship, but more like somebody she really cares about. And I think that is what comes out in every interaction with her. Whether it is about medical advice or it's about anything else, that feeling of a personal relationship and a friend is what comes out everywhere. And therefore, apart from being a doctor, she's an educator. She teaches postgraduate courses and specialized courses in her area. She is also very, very concerned about making sure that there is good health all around, and therefore she does a lot of awareness programs in colleges and in various public fora. She has a lot of publications to her credit. She has written book chapters and is extremely well regarded in the academic as well as the medical circles. But apart from her professional career, she is also very fond of music. She's very, very deeply into Carnatic music. She's a good painter. She's one of the first painters that I saw take to the electronic medium. So she's churned out some really beautiful paintings. She is a photographer and travels, despite that heavy schedule of hers, she finds the time to travel and is also very much socially involved. So we're very thankful to her that she is with us today. and look forward to your talk, Uma. Thank you.
Thank you very much, Sushila, for that very generous introduction. I'm not sure, if all of that is deserved, but thank you very much, and thank you for this invitation. So when Sushila asked me to speak about a topic in relation to maternal health, I was more than happy. Traditionally, when we talk about maternal health, we focus a lot on the pregnancy itself and its care. Today, I thought I'll take a slightly different take on something on have long-term impact. And we are a small group, so I'm happy for it to be, if you want to stop me at some point in the middle of the presentation also, I'm okay. Or if you type your question on the chat, that's also fine. So with that, let me just start off and just ask a few, ask you to just kind of tell me or put down in the chat what you think are the most common medical problems in pregnancy. If I asked you to name a couple of common medical problems in pregnancy, I'm just trying to see if I can see the chat box. See the chat box when I'm presenting? I don't know. I'll have to open it out, I think, on the side.
So I can call out if any questions are there on the chat box.
Yeah, okay. All right. So, yeah, so, and then you can, I think that all of you would probably have thought of diabetes and probably thought of blood pressure in pregnancy and anemia. Yeah, I can see both those problems. And how common do you think diabetes is in pregnancy? Not very. Okay. And, do you think when somebody books in pregnancy, can you actually identify and say that this woman is likely to run into trouble and this woman is not? Are we good at that? Or do you think we are good at that as doctors? Sushila says quite common, Dash says not very. And yes, we can identify women at risk in pregnancy. And Chaitra says not really. Okay, so we'll look at some of these factors in the course of the presentation. So traditionally, care of women is focused around reproduction. And I think all of you will agree to that. Women seek care when, if they want to have a baby, while they're having the baby. Typically, after that, they forget about healthcare. Except, I guess, if you're in a corporate setup or you have somebody who's telling you have to have a health check mandated. The next time they access healthcare is once they have a medical problem. But we are increasingly understanding that the reproduction is just a very small part of the entire life course of a woman. And yet the majority of the focus is around that period of time. Not just by the woman herself, but indeed by the family. And that's remained the traditional focus. It's also the traditional focus of most policy and most initiatives that focus around maternal and healthcare. So it's not just individual, it's also the system. So I want to bring up, say a story, and the story may relate, some of you may relate to this story because you are friends or family. And this is a 45-year-old woman who presented with irregular heavy bleeding after not having a period for 3 months. Her BMI was 38, her blood pressure was 150/100, and clearly she was diabetic. Her HbA1c was 6.8 with a fasting sugar of 118. If we went back into her history, she had trouble conceiving, she had irregular periods, she conceived with treatment, she had pregnancy-induced diabetes. Post-pregnancy, her sugars became normal. She got pregnant again after a few years. This time, earlier on itself, her sugars were higher and she needed insulin this time. And she also developed high blood pressure in pregnancy. Now at 45, she had type 2 diabetes. She had lipid problems. She has had ischemic heart disease. And the gynecologist investigated her irregular bleeding, there was evidence of hormonal imbalance with undue thickening of the uterus lining. While we see her, it is not uncommon for her to be accompanied by her 15-year-old daughter, who also has irregular cycles, is worried because her face skin is not clear. She has acne and her BMI is 28. And in passing, we just talked to her about the importance of exercise and diet. But she comes back at 23 with some fertility concerns, has full-blown polycystic ovarian disease and impaired glucose tolerance. And the story actually will go on because if this woman, then the 23-year-old becomes pregnant, she's going to have diabetes in pregnancy. I don't know how many of you have seen the movie Groundhog Day, but there is this movie where this man wakes up every morning and he's actually going through the same day. And every day he realizes that he could have done something different and the day then turns out differently. And I think when very often we see women who have this pattern and presenting to you, you really wish you could turn the clock back so that they had the benefit of intervention before they actually had a problem. Now, if you look at this not as an individual, but at a national level or even a world level, we know that non-communicable disease is the burden increasing in the developing world. And, there are publications in the lay press, there are publications in journals like The Lancet, which actually look at how is this NCD burden, increasing in different states. And you can see between 1990 and 2016, the burden of non-communicable diseases has virtually doubled, right? So this is all, fairly dated reports from about a decade ago, but you can see that there is a huge increase in the burden of NCDs, which impacts a lot of things besides health. It impacts work, it impacts your productivity, and virtually 1 in 5 women have gestational diabetes. In fact, if you look at the data on diabetes in young adults, you'll find that there are more women than men with diabetes in the age group of 20 to 30. So it is not surprising that hyperglycemia or diabetes is common in pregnancy. And this is from a publication where the author says that cardiovascular disease is actually the leading cause of death in women worldwide and the most common cause of disability adjusted life years. And in general, this is very under-recognized. And women are disadvantaged in terms of identifying cardiovascular disease because women don't present typically clutching their chest with pain, chest pain, which is what happens to men. The symptomatology of women is different. And they actually, when they present with cardiovascular disease the first time, it can be more severe. And a larger proportion of them can actually have a significant event, including death, at their first presentation. But health care and research in health has always been skewed towards the mother and the baby, whereas actually we need to redefine what is meant by women's health to encompass the whole life cycle. And the reason I'm putting the statement out there is this is a shift in the thought process of the medical profession in general. But I believe that this understanding has to go out into, out of the medical profession to reach women, because only then will they seek help or, be able to put in interventions in place. So traditionally, there are 3 points in time where a woman comes into contact with healthcare: after she is born, And usually the first touch point is pregnancy, the second touch point is in the postpartum period, and the third touch point is once they develop chronic disease. And what I'm going to kind of put forth to all of you is that we can actually use the first two touch points as flags to identify women so that you can prevent chronic disease or the burden of NCD. And there is an increasing understanding that we can use pregnancy as a window of opportunity to look at her future health index. And this is again a statement where we as doctors ourselves are actually are only now beginning to realize that when a woman develops a complication in pregnancy, we say she fails pregnancy because she develops high blood pressure or she has a late miscarriage, she loses a baby from stillbirth. So the degree to which this happens is a stress test, and each of these abnormal pregnancy outcomes reflects that she's at risk for future cardiovascular disease. And the severity and the number of times she fails in pregnancy actually increases not just her risk, but the time frame over which she's likely to develop cardiovascular disease. And there is a good amount of data. So what we understand is that there is some baseline abnormality, which could be in the metabolism, which reflects as insulin resistance and therefore diabetes, or something that reflects as a cardiac problem or what we call endothelial dysfunction. That is, there is some abnormality in the levels of the blood vessels. And this then comes up as a blip during pregnancy as a problem, which traditionally even doctors believed is something that is induced by pregnancy and goes away after pregnancy and will not affect the woman later on. But we have an increased understanding that this then increases the chance of her developing cardiovascular disease significantly in middle age. And so this is data from, from Canada, because in countries like Canada and, in the Scandinavian countries, they have the benefit of extremely high quality national health data, which unfortunately we lack, even though we have the volume. And this is data from Quebec, where they actually said that 5% of women experience a severe maternal morbidity, which means they have a significant complication, but they survive and they don't die. And these women who have this morbidity have an increased risk of getting hospitalized for a cardiovascular disease by 77%. And this remains high after adjusting for age, socioeconomic deprivation, other comorbidities, etc. And the highest risk was within the first year, but the risk remains persistent for after 15 years. And this is very, very concerning, because if you think of a woman who's having a baby, even in countries which are in the Western world, they would be in their mid to late 30s. And we are talking about significant cardiovascular morbidity, even though it may be 5 or 7% of women, within a year or 3 to 4 years of that, which means that by the time they're in their 40s, they're going to have a significant cardiovascular outcome. And even in Quebec, a third of them were younger than 25 years, and another third were between 25 and 29. And that is not the age group where we anticipate that we will have cardiovascular disease. So the traditional cardiovascular risk factors, all of you know, hypertension, smoking, diabetes, physical inactivity, etc. To this, the American Cardiac Association has actually added a whole bunch of terms which are all complications in pregnancy. Preeclampsia is high blood pressure in pregnancy, diabetes in pregnancy, having a very small baby or growth-restricted baby, having a baby preterm, that is before 37 weeks, and definitely if it's before 35 weeks, having excessive weight gain in pregnancy and postpartum weight retention. And that is a huge problem in India, because we believe that women have to eat for 2 people when they're pregnant. it is not uncommon for us to see women gaining 15, 20 kilos, even though they're starting off with a very high BMI. And I personally believe doctors are partly to blame for this, because a lot of doctors are worrying women and not asking them to exercise, putting them to bed rest, and that compounds the problem. So, so this is basically to say that if you have a woman who has preeclampsia, which is high blood pressure, versus no preeclampsia, their risk of all these problems is significant, at least 2 times or 3.6 times more. And the increased risk of cardiovascular death is also high within 10 years, which means if you have a woman who has very high blood pressure and delivers at 27, she has a risk of cardiovascular disease by 37. And this is the kind of numbers that actually we should be scared about and we should be doing something about. So that's about blood pressure. The next is hyperglycemia. I mean, we are the diabetic capital of the world. Again, not something that we should be proud of. This is the projected increase in the Southeast Asian region. That is a 74% increase is what the International Diabetic Federation is projecting. And it's also the region where the system, that is healthcare systems and governments, are putting in very, very little in terms of expenditure into prevention, is also in the Southeast Asian region when compared to all the other regions. The proportion of births that are affected with diabetes or hyperglycemia is 15.8%. So in India, you can actually see the average is about 20%, which means 1 in 5 women who walk into our clinics pregnant are likely to have some degree of glucose intolerance. So it is not uncommon, it is quite common. And that's 20 million births is a large number. So 1 in 5 or 6 women have hyperglycemia in pregnancy. And all these women are at risk of developing type 2 diabetes. They're at risk of developing cardiovascular disease and metabolic syndrome, which means hypertension, lipid problems, etc. So this is data from our own studies, which we have done in and around Chennai, where if you took women who had pregnancy diabetes, within 1 year, 20% of them had abnormal glucose values. The 47% pre-diabetes and 10% diabetes is a study from AIMS within 4 years. So again, we're talking very, very young women who are going to have metabolic problems very soon. And therefore, there are directives on how to screen them, how to bring them back, do a test at 6 to 12 weeks post-delivery, then test them every year. But the same mother or the same woman who is so committed to maintaining her glucose control because she's going to have a baby, the moment she has the baby, will forget about it. So unless we are like super motivated team, world over, the follow-up rates of bringing women back after 6 weeks and getting them to check their sugars is an abysmal 40–50%, right? So something happens. So again, so this is a gap that we need to bridge in some way. And so what is even more concerning is data that this effect is intergenerational. So if you have a mother who's had a daughter who was born prematurely, when this preterm baby becomes a mother, her chance of developing hypertension is higher. So this is a situation where you can have an intergenerational effect. And the other area where there is a lot of concern, increasing awareness is mental health. And NIMHANS in your city is the first institution to have a perinatal mental health setup. And I've actually collaborated with them to set up a training, a module for obstetricians to understand about perinatal mental health, because most obstetricians ourselves tend to poo-poo the fact that this woman is teary and say this is all going to happen. And traditional supportive families, the buffer that possibly a extended family was giving in the past is no longer there. And, there are so many other pressures that women are going through that there is definitely an increase in postpartum depression. And this then is known to affect bonding. And in India, the prevalence of perinatal depression, which is again very huge. We're talking 1 in 4 to 5 women who are having babies. And if there is depression, then this again translates into poor health for the baby. So, I mean, it's not all doom and gloom, but we need to then identify that this is a problem and put together interventions to reduce risk. And this includes actually what we call early postnatal care. So not just tell the mother, okay, now that all the focus shifts on the baby and we are just asking her to take care of the baby and feed. And, if both the family and the clinician shifts focus, then we drop the ball, because there is no system in healthcare to handhold and transfer the care of this mother from an obstetrician to a physician. There isn't a system that exists. And this is something that we are trying to work. We handhold and transfer the baby to the pediatrician, but there is no family physician. There is no transitional clinic to say, hey, this lady's had blood pressure in pregnancy. She's had diabetes needing insulin. She needs to be watched. And that is something that we need to do, as well as tell the woman that you need to be aware that you have to be watched, because only then will the motivation for her to come for checking happen. So it is a teachable moment. And again, in Canada is where they have put such clinics in place, and we probably need to learn from them. You just did a very nice presentation on a project to support lactation, and there's extremely good data that breastfeeding protects against cardiovascular disease. Besides the traditionally known protection from breast cancer and the value for the baby, there is effective risk reduction both for type 2 diabetes and for cardiovascular disease in mothers who breastfeed, which is why we very, very strongly encourage women with diabetes or women who have pregnancy hypertension to breastfeed. Now, what do women want? Women are actually often unaware of all of these complications. And when they come after their baby, they basically want a sense of positivity, positive motherhood. They want to be able to cope and adapt to changes, and they want to regain health for themselves and for their baby. And this is what has come out of various, group discussions and things that people have done. But they need to be given the knowledge that they are at risk, and B, there is intervention that can minimize the risk. And unfortunately, the intervention that is most effective is the hardest to implement, because it is all lifestyle-based intervention. It's not an easy pill that any of us can prescribe. And the moment you start talking to a new mother about diet and about exercise and the need for sleep, we've lost the ball, because we don't have the means of supporting them to sustain that intervention. But and this is unfortunately the only thing that is going to work. And this is a document that came out last year. This is a large, long document from the WHO on positive postnatal experience. They came out with 63 recommendations, and we wrote a comment on it. It completely misses the long-term perspective and focuses exclusively on the first 6 weeks. And 6 weeks is simply not enough from the point of view of postpartum, especially for women who are at risk. So we need to basically triage women, because a new mother may be completely low risk and she may not need anything except a supportive family and, to take her through. But increasingly, because we are taking care of older women who are having pregnancy complications, we need to understand that when they have complications in pregnancy, we actually have the opportunity to pick a group of women who are at highest risk of developing non-communicable diseases going forward. And it's an opportunity that we need to optimize to defeat this burden of NCD, which is rapidly climbing. And you have large number of government programs, initiatives on NCD prevention. But with women, we have a wonderful opportunity, which we have not yet managed to crack. Now, I want to shift focus and talk a little bit about how the pregnancy is going to affect the baby. This was on the cover of the Time magazine 13 years ago, when we first understood how the first 9 months will actually shape the rest of our life. And there is this understanding of the developmental origins of health and disease, that what this baby and its genetic material is exposed to when it's growing, he or she is growing inside the mother's womb, can cause an epigenetic change, which is a small change in the environment which alters the working of genes. So, and this is very classically true in mothers who have diabetes, because that high blood sugar, obesity, they all cause epigenetic changes. And especially if the baby that is growing inside the woman who is obese or diabetic is a girl, then that baby girl's oocytes, which are still, really, really kind of small and non-functional, and within the mother's womb are exposed to the high blood sugar and the epigenetic changes. It changes the way she is going to be as an adolescent and increases her chance of developing hypertension, obesity, etc. So there is, there is a huge impact that we can do by taking care of pregnancy. And I think we need to go, I think we are to some extent coming away from the fact that we all think that Glaxo babies are the best babies to have. And, this was again another comment in the Lancet Diabetes 2 years ago, saying that it is neonatal fat that is associated with childhood obesity, and reducing neonatal adiposity should become a public health effort. So we are all, so it all boils down to what we eat, how much we exercise, what we do in pregnancy, and probably we should go one step ahead. And because these are all the implications on the baby. And today, if you see that, it's not just the labeling, there is a concern that ADHD and all these autism spectrum disorders are all increasing. And a lot of it may be due to the epigenetic changes that these babies are getting exposed to in utero. And we have very little understanding of what actually goes on that influences the brain of the child that is growing within the mother. So if we go back to the first story, this lady who conceived and had pregnancy sugars, if she had had adequate nutritional advice on the importance of diet and exercise and had intervention, then she could have prevented becoming a type 2 diabetic, because we know that there is prevention possible. If she had, not gained that much weight, she may not have had a hormonal imbalance. Her PCOS could have been addressed, and then she may not have had endometrial hyperplasia. But at least now we have that opportunity to intervene on this 23-year-old who has fertility problems. The solution actually, before we offer her treatment for fertility or IVF or whatever, is to tell her, hey, you need to get your, lose weight. You need to actually, and not just say it, but provide some support so that she's able to achieve it, so that when she gets pregnant, her baby is not going to follow the same loop. And, we can potentially reduce the intergenerational transfer. So I think I'll kind of wind up now. The point I want to make is that, yes, pregnancy is a very important period. I'm not taking away from the fact that we need to provide appropriate care to ensure that we have a happy mom and a safe baby. But we need to understand that there is an influence of pregnancy that goes beyond childbirth. And while we are focusing on this little baby, we also must remember that there's a mother that is going to have problems, and she needs to be around to take care of this little baby. And that baby is going to grow up and have babies which will be affected by what this baby was exposed to within his or her mother's womb. So we need to reduce this intergenerational transfer. Thank you very much. And I hope with that I wind up, and I'm quite happy to take any questions.
Yeah, thank you, Doctor. It was really nice to hear you. I have got a question here, which I'd like to know. You see, you have talked a lot about how the mother can take care of herself. Okay, I mean, it is during pregnancy and what are the kind of complication that might come. We also, in our country, we notice that there is a child mortality rate is very high, even after the baby is born. What do you think there is any particular reason, or it's the lifestyle, or it's the medication? What is the reason actually?
So I think you're right. There is a large burden of infant mortality and neonatal mortality. And it's improving, but the commonest reasons are malnutrition, infection, and those are the two most, and small babies. These are the most common reasons. And as you know, I mean, India, as with everything else, the average doesn't tell the stories. You have states in the south where huge progress has been made, both from maternal and infant mortality rates. But if you go north of the Vindhyas, the story is completely different. So infant mortality, a lot of it is the fact that low birth weight, malnutrition, infections still.
Okay. So, and especially this happens in the rural areas more than the urban areas. That is also true, isn't it?
It is, well, rural or urban, certainly rural and urban, the complication rates in pregnancy are all merging. But I think socioeconomic divide is stronger than a rural-urban divide.
Oh.
That is my understanding.
Okay.
Again, when you say rural, it depends on the quality of healthcare that is available. Rural in like in southern states, the rural healthcare is much stronger than you have in some other states, isn't it? So there you may not find that the divide is so much rural, urban as socioeconomic, but yeah, certainly I think in some parts of India, the divide will be more rural.
Right. Anyone else would like to ask a question to Doctor?
May I, Gargi?
Yeah, please go ahead, Shushila.
So Uma, you said that the nutrition program that we are running is a good idea. Is there anything else that we can do alongside that to kind of, how do we build on that project? What you talked about is creating an awareness that goes beyond just supplying nutrition. Is there something we can do about it?
Yeah, so I think what is eminently doable is that for the mothers to whom you're supplying the nutrition, you can actually have a checklist and ask, did you have pregnancy sugar? Did you have hypertension? Did you have, obviously if they had a stillbirth, they're not going to come into your program. But Did you have a very preterm baby or a very low birth weight baby? Because these are the 4 scenarios where it puts the mom at higher risk. And it also puts the baby at higher risk if the mother's had diabetes or the baby is very small. So alongside this, and you could look at if the answer to any of these 4 questions is yes, then maybe you can tell that woman that, you know, you need to actually also have your sugar checked after 3 months or 6 months, or have a blood pressure checked or see a physician. You know, something simple like that can be done. It's a wonderful opportunity to intervene, actually, to add on.
Thanks. We could, yeah, probably we could add a doctor alongside what we are doing. And, you know, you talked about also things like making them aware about physical activity and so on. So probably that's another thing we could add on alongside.
So we did a project on pregnancy diabetes, Sushila, about 4-5 years ago. In which we gave women pedometers in order to track their, you know, activity. This is in the city of Chennai. Middle class and upper middle class patients who are coming to some of our centers. Take a guess how many steps they were taking in a day.
3,000.
3,000. Yeah. And the recommended exercise in pregnancy is half an hour at a minimum of moderate intensity exercise, 5 days a week. That is the recommendation. Okay, and we are to blame because I don't think half the doctors tell the woman that that is the recommendation, but 3,000 steps. So physical activity, where do you have to build it, no? If they've never done anything. So it's the hardest kind of advice to give. And it's hard to give it to a mother who's breastfeeding, who's not sleeping. And our postnatal nutrition, traditional postnatal nutrition has many benefits, but it can have its own problems also, because sometimes protein is restricted. Sometimes those laddus are like heavy duty ones. So those things we have to work around.
I think probably Madhu this and Shushila also, like in our program, we will try to bring in some kind of a improvisation and probably few touch points where we feel what we have heard today that can be implemented. So our project will be more effective. What do you say, Shushila, about it?
Agree completely.
Yes, that's true.
I mean, I'm happy to vet a questionnaire, a simple one that they can, you know, just basically risk categorize the mothers and the babies. Then you can decide what you want to do after that, but you'll have the data on hand.
Yeah, I think if there is some simple checklist, then it's just a matter of ticking and, you know, saying in which risk category they fall and things like that.
Yeah.
Probably, yes. Is there any other question? I guess not. Well, I would now request our past president, Dash, to give the vote of thanks.
Newly minted President Gargi, our distinguished speaker for the evening, Dr. Uma, and of course, all my dear friends today. It's my pleasure to offer the vote of thanks for the very first weekly meeting. This month's theme, as per Rotary International, has been maternal and child health. As a golfer, I'm sure you'll permit me to say that nobody could have teed it up better than Dr. Umar today. It was very informative and a great start to the new Rotary year. We know that every day millions of mothers are giving birth and millions of children die each year, largely from treatable and preventable diseases, as we found out in today's talk. Statistics say that at least 7 million children under the age of 5 actually die each year due to malnutrition, poor health, and inadequate sanitation. All of that is preventable. And to help reduce this rate, and especially since we have so many new Rotarians in our club, I would like to reiterate that we in Rotary provide immunization, antibiotics, improve access to the essential medical services, and support the trained health staff, care providers. And we show our own in Rotary and in Bangalore Cantonment especially, we show our own human milk of kindness through this wonderful Lactating Mothers program. And Rotarian Madhu, thank you for taking us through the details on that. And as we saw in Dr. Uma's talk, there's a very clear link between CVD and helping the lactating mothers. So it turns out to be very, very appropriate. Dr. Uma, of course, did show us why taking care of the health of the mother is so very important. And she did that through wonderful case studies, not borrowed from Harvard, but from her own clinic, Seethapathy clinic. And therefore, that makes it that much more relatable, doesn't it? And if we hadn't heard Dr. Sushila introduce her, going by the quality of the presentation, we could have easily mistaken for a data scientist. Dr. Uma, such were the qualities of the graphs and the statistics you showed to buttress the powerful arguments that you made. Thank you for that. In general, especially in India, we have made tremendous strides in healthcare, maternal deaths, various statistics, but somewhere around 25,000 per annum, down from 45,000 in 2016. So a very steep, precipitous fall in just 7 years, which augurs well. And as we saw today, it's very important to link the maternal health through pregnancy and therefore the aftermath of the child, which very often we save the life of. And I'm reminded of James L. Boehmer Jr., who was a former Lieutenant Governor of Tennessee, who apparently said, "What is the life of one child saved?" And he goes on to say, "No one will ever know, but if the child were our own, the price tag would read, 'Not for sale, for this life is invaluable.'" And of course, today we have MasterCard, which says priceless. So that saving of one life through timely interventions is such a powerful imagery. Thank you, Dr. Uma, for taking us through that again. And we heard you're a doctor, you're a gynec, an educator, a photographer, a painter, and as we found out today, a superlative presenter. We'd like to take this opportunity to thank you for taking, we know as a gynec and an obstetric, time is never your own. So thank you for taking time of this evening and especially taking us through the spectrum of what this whole pregnancy and life of the women, the mother and the children, especially the intergenerational one transgenerational one you talked about. And we would like to thank you for a very, very wonderful talk this evening. Thank you.
Thank you, Doctor, once again. I think nobody could have been give a vote of thanks better than Dash, the way he has explained and the way he has listened probably each and every slide, observed everything. Hats off to you, Dash. Okay, and thank you once again, Doctor.
Thank you very much. Thank you. Thank you, Dash. Thank you.
And I
all for logging in. Whoever logged in, thanks a lot.
Yeah.
Thank you, Doctor. Thank you.
Thank you. And I adjourn the meeting. Thank you all.
Good night. Bye-bye.
Good night. Bye.
Thanks.